welcome back to another episode of Ask Physio Live. Hope everyone had a really nice Saturday, and I'm just going to wait for a few people hopefully to jump on here. And there's my mother, first on, standard. Hi Marie. Alright, I am a one-woman band tonight. Anyone that caught me last night would have seen that Oliver is not here tonight. There's Jason on as well. Hi Jason. He's just booked to come to Ireland in July. Can't wait to see him. Okay, so yes, Ask Physio Live. If you have any questions for me, I have two really good questions that I'm going to get stuck into very soon. Hi Jason. Jason just commented. That I am really eager to answer, but I probably have time for one more. So if you have any questions for me, please comment below or send me a direct message, and I will do my best to get back to you soon, to try and get to it by the end of this video. So we're on episode 33 this week, and Physio news is that I have no Ollie, just upped and abandoned me. He is in Kerry, in Dingle, at his friend Paul's stag, so not appropriate to have him on Physio Live tonight. So I'll try my best to get through this on my own, so bear with me. Physio news. Standard week at Physio, nothing too exciting happened. We do have our arthritis courses starting in Tuesday week, and both courses now in Galway and Donegal are filled up, so we can't believe that. We're delighted and we're really eager to get them started. Hi to Caroline and Regina, have just jumped on. We had a great day today. I have to do a shout out to Regina and Marie. I hope everyone had a lovely Saturday. It was really sunny here and we spent the day shopping. Yep, so great day with Auntie Magella, Regina and my mum. So it was lovely and it was just so nice. I'm going off kilter here at Physio News. So yeah, the arthritis courses are now filled in both clinics, so it's great. But if anybody is interested or would like to come, can you please just send us a message anyway, because we have a cancellation list in operation. And I posted yesterday about all of the class spaces that we have in our classes now, having sort of rejigged the classes at Easter, coming up to Easter. So no other news, I think. Oh, I nearly forgot. I have to do a major shout out to all of the Irish dancers who are competing in Glasgow in the Worlds this weekend. A few of our dancers in two of the local schools in Donegal are competing, and these kids, if anyone out there obviously has children or relatives that dance, they know how amazingly hard they work. They're just complete little pros, and we have had the pleasure of working with them over the last sort of 3 months in our dancer Pilates classes, and we just wish them all the best this weekend. Dance their socks off, and hopefully all their hard work will pay it off, because they are phenomenal. So a big shout out to everyone in Glasgow. Good luck. Right, let's get to these questions. So the first one, which I told you about yesterday, was about a knee. All right, let me just bring it up, but I'm pretty sure I know the gist of it. Okay, so this post came in from a 42-year-old female who said, I've just been told I have a meniscal tear in my knee. My scan showed I have a meniscal tear in my knee. What does this mean, and can we do anything to help? Okay, so a meniscus and a knee. I'm going to try my very best now to explain this. I've taken my knee model here to talk what's going on. So to this person, first of all, females and 40 is a sort of a target audience this can happen to, maybe sometimes a little bit over 40, but let me explain. This is a model of our knee joint. What you see in front of you here is you can see 3 of the bones that make up our knee joint. This top one is our thigh bone, bottom one is our shin bone, and the little one on our outside is called our fibula. Doesn't have a lot to do with the knee movement. And then on the back here you see the 4th one, that's the back of the kneecap. The kneecap is embedded in this piece of tissue here, which is the end of the quad muscle, the big muscle at the front of the thigh. So we have 4 bones that make up our knee joint, and it's a hinge joint, bends and straightens mainly. There's a tiny bit of rotation, but not much. These pink sections here, or orangey, these are representing the ligaments of our knee. So ligaments connect bone to bone, and you can see there that ligament connects the top of the thigh bone to the top, bottom of the thigh bone to the top of the shin bone. There's one on the outside that attaches from the fibula to the edge of the femur, and then we have two big ones that cross over the center. You can see one there, and this poor guy here has ruptured one on the front. There are ACL and our PCL ligaments, often injured. The footballers often injure them. When we talk about meniscus, though, we're talking about this blue stuff on the inside, wedges of what we call cartilage. Now, in the knee, there's two types of cartilage. There's a very light layer of cartilage that covers the ends of the bones that are at the end of all of our bones and within all our joints. But in the knee, we have these extra wedges of cartilage. You can see them there that sit inside the knee joint. So they sit like this. All right, and I'm going to take them out just for teaching purposes here. So it's two thick shapes of cartilage, nearly like the material in your ear. That's what it feels like. And they're used as shock absorbers. So when we're walking around, hopping and jumping, some of the forces are absorbed through these chunks of cartilage. Now, you can see here that they're crescent shaped, so C-shaped, and this one on this side is a bit more round than this one on this side. You can see it has wider insertions. And through our life, these meniscus, they load up every time we're moving. And it is very common for these meniscus over the years to have little tears within them. There's different types of tears that they can get. So sometimes it's just fraying around the edges. Sometimes you'll get a chunk through the center where somebody's sort of gone down and twisted on their knee. You might get a slit across here where you can go right through to the bone, but the actual ends are still together. You can get little frayed tears on the edges of these meniscus. Now, when it comes to clinic and meniscal tears, most common, there'll be two types of presentations. Presentation A will be somebody that's come in. They could be young, active, or they could be middle-aged, active, and they will report to us that they had a twisting injury of their knee. And that injury will then give them a meniscal tear when we go on to do our assessment. Often, when patients do their ACL, so when they have a big rotational twisting injury to their knee, they will often injure their medial, the meniscus on the inside of the knee when they've done that injury. In terms of then the second subgroup that come in with these tears, they're often middle-aged females and they have no history of specific trauma. They will say that their knee, usually again, the inside portion, they'll have pain on the inside of their knee and they won't be able to tell me why it started. So it might have simply happened one day when they were getting up from the floor, or they were doing a lot of cleaning, or they were walking upstairs, but no twisting incident. That's the two most common cases of meniscal injury that we see. When they come into clinic, what do they present like? They may be getting recurrent swelling, puffiness in the knee. When you look at both knees, one looks a bit puffier than the other. Often they'll have joint line tenderness, and in most cases, even though they can have lateral meniscal injuries, it's often the medial meniscus that has more problems. So the inside of the knee will be sore. All right, so recurrent swelling with pain on the inside of the knee. On assessment, when I palpate, so what I'll normally do is when their knee is bent up, I hope I'm not boring you here, but it's just to give this lady a little bit of an idea of what's going on. We'll often get them, my poor knee has seen better days as ligaments are tearing. When their knee is bent up, I'll often feel down the front here. There'll be no pain, no problem. And then I'll move my finger over and palpate around the edge. And when they have a medial meniscal injury, there will be point tenderness normally on the inside of that knee. So recurrent swelling, pain on the inside, point tenderness. Often then when I get them to crouch down, so either deep squat or crouch, they'll get the pain on the inside. And that's because when you deep squat or crouch, you're putting the pressure on that meniscus. And often we'll do a test where we bend the knee in and rotate the pressure on that side. If that reproduces our symptoms, then we're more suspicious of that meniscal tear. Now, these patients, just to be clear, just because they have a meniscal tear does not mean that they're going to have ongoing recurrent problems with their knee. There is a 2012 study, it looked at, I can't remember the numbers, it was over 700 people, pain-free people with knee pain. I can look it up and link it in. Between, I think it was like 50 and 70, and 68% of them had meniscal tears. So there was meniscal tears in these knees and they had no symptoms, pain-free. So that's the first thing I say to my patients. Just because this meniscal tear is symptomatic now doesn't mean that you need to go on and have surgery. We can usually get these symptoms calmed down. All right, so a meniscal tear means that you've got a little tearing to the cartilage on that knee, and you can let me know if it's the inside or the outside, but 40-year-old female, I'll put some money on it, there's probably that inside of that knee hurting most. So what do? Can we help? Yes, absolutely. There is good research to show that strengthening around that knee will help reduce the symptoms of these meniscus. And for these patients, I am very honest with them. I say, look, I think there might be a little meniscal tear there, but let's try and rehab this and see how it goes. I will give these patients 6 to 8 weeks of good physio, and if things start to settle down, I know I'm onto a winner, and we can probably calm this meniscus down without having to do anything else. So what will I do with them? I'll make sure, first of all, that they've got full knee range of movement. All right, so if there's any stiffness there from the swelling, I'll do mobs on that knee and I'll give them exercises for home to keep it moving. The second thing I'll do is strengthen up the muscles around this knee. It's very simple, folks. The stronger the leg is, the less pressure that has to go through that meniscus. The stronger your glutes are, the stronger your quads are, the stronger your hamstrings are, the less pressure goes through this blue piece of material, and therefore the less likely that your tear will be symptomatic. So all of my patients will leave with a strengthening program for that knee. And they will know very quickly that things will start to settle down and they're on to the right road. So in most cases, it will calm down beautifully and I can get that patient back doing what they need to do with no problem at all. Now, the problem is that this piece of material, the cartilage, has got a poor blood supply. So healing of that tear often does not happen easily or well. And that means that's why you have patients in their 60s that have these cartilage tears. They don't heal well. It's not like when you cut your skin, it has a really good blood supply and it heals really quickly. That unfortunately doesn't happen with this cartilage. So what often happens is that we get you to a point where you're managing what you need to do with the meniscal tear. It doesn't often repair. Now, in some cases, for some patients, we will do all of that rehab, and this darn knee will keep swelling up. And if anybody's watching that have had a meniscal tear that maybe this has happened to, they'll notice that they're getting frustrated. They're like, why is this not working? They'll be fine for a few weeks and then they might try and, do something a little bit different, go for maybe a hilly walk, and next thing the knee balloons up on them again. That is a recurring flare-up of that meniscus. And in some of these cases, if I've tried everything, I will send that patient on to orthopedics to have a very simple keyhole procedure where they scope, in most cases, particularly for the middle-aged females that present with this problem. They'll go in with a little scope and just shave off a little edge of it, and then within 6 weeks I can have that patient back running again. For my ACL patients, often when they're doing the ACL repair, they'll have a look at the cartilage. Hopefully it's a tear, a tear where they might be able to suture it back, the cartilage together, and preserve as much of it as possible. Or sometimes they'll shave it off if they can't repair it. So sometimes if it is causing recurrent problems, it's a very simple scope procedure. But either way, to this lady, we can solve this problem. In most cases with good physio, and if it doesn't, we have options as well. So please contact your chartered physio, and they should be able to talk you through this and explain exactly what's going on. So that is a meniscal tear in a knee. It happens most common secondary to fairly rotational or compression injury, where someone has come down on their knee hard and then perhaps twisted slightly. Or that's in the younger population, 35, 40 plus. It can happen very simply from getting up from kneeling or something like that, an awkward position. You won't have noticed you've done it, and it can happen. But remember, meniscal tears are present in 68% of people in a study of 700 people that our knees are pain-free. So just because you have a meniscal tear doesn't mean that you have to accept pain in your knee longer term. All right, meniscal tears, we can help. Good, hopefully that was helpful. Any other questions, please keep them coming if you have anything for me. I have one other really interesting one. I'm not sure how much I can help, but I'm going to give my 10 cents on it anyway. I hope I'm doing okay on my own. It's a lot of talking, but all I know is that that's usually a problem. Sorry, drop that phone down. Right, second question, and I hope this person gets the answer to this, because they actually asked this question over on Instagram, so I'll link it on Instagram later. Okay, so this is a woman's health question, anonymous of course. This lady 8 months after a traumatic forceps delivery. This patient had a prolapse of their bowel. All right, I'll explain what that is in a second. I'm pregnant again. My midwife recommends a section because of the prolapse, but my consultant seems to think there is no reason why I can't go natural again. Would love a physio's take on this, as I'm concerned about muscle damage and possibly doing irreversible damage because of prolapse, if this makes sense. Right, women's health. Sorry now, I go from meniscus to women's health, but hopefully there'll be someone out there that might find this helpful. First thing I want to do here is explain exactly what this person means when they've had a bowel prolapse or rectocele. And a picture paints 1,000 words, and I think I have one here pretty handy, so I'm going to try and pull this up and just make sure I get up the right one. Yeah. Okay. So women's health problems, I absolutely love helping with these if I can. Now this question, not so straightforward, but I'm going to try my best and kind of give you my piece on it. So here is a picture coming in your direction. Hopefully the light will allow you to see that. Alright, so what you're looking in front of you here is, this is the pubic bone in front. So this is a side view. If you're looking at a female anatomy on a side view, this is their bottom at the back and pubic bone at front. You can see their bladder here. This is the womb, the vagina, and then the back passage. I hope this is appropriate. Yeah, it's late enough on a Saturday night to be showing this on Facebook. Sorry if I'm offending anyone. So what you see here, this is the back passage, where it comes out the bottom. Normally this little section here that you see, it shouldn't be pouched down like that. It should be straight up. So this picture shows a rectocele where the back passage has fallen slightly down into the vaginal wall. This patient may feel that, you know, inside. They might feel something coming down inside. They might be struggling with emptying their bowel properly, where some stool can get caught here. This can happen secondary to, in this patient's case, oh, somebody's giving me an angry face, I'm sorry, but this is real life, this happens. So this happens usually from a forced delivery, which can happen, you know, they have to get that baby out. So what this patient is asking me is that they're pregnant again. They want to know if doing another vaginal delivery through this passage could possibly make these symptoms worse. All right, it's an age-old problem. If you have a prolapse, you're having a second child, what do you do? So, you know, the opinions on this are going to vary. What I try to do is go back and look at the research on it. You know, have we studied this area? Do we know the facts? And when this question came in, I got really into it and I started to look. Bottom line is, the information isn't fully clear. We don't know the correct answer, which is why your midwife and your consultant is giving you two different opinions. Now, what I did find was a study, a UK study from 2012. They looked at patients who had surgery for pelvic problems, so either a bladder prolapse, a uterine prolapse, or a rectocele. So they had their surgery, their pelvic floor, their repairs done, and then we're going to have a second child. All right, so they've had pelvic organ surgery, having their second child, and they were trying to decide whether they'd have a C-section or whether they'd try a vaginal delivery. So these ladies had trauma where they've had to have surgery, and then we're trying to make the decision again, do they do C-section or they do natural delivery? And it was really interesting. There's 603 women studied who all had pelvic organ surgery and now run their second birth. What do they do? And they followed them to see what the incidence was of these women having to have surgery a second time. And of the 603 women, 6.9% of them who had a vaginal delivery went on to have a second surgery. 4.4% of them who had a C-section went on to have another surgery for their pelvic organ problems. So what does that tell us? It tells us that if you've had pelvic organ problems and you do a vaginal delivery, yes, there is a small chance that you can have further problems. But also it told me that there's a 4.4% chance if you have a section, you can also have further pelvic floor problems afterwards. So you are between a rock and a hard place. There is no right answer here. When we bring it back to basics, the risk factors for having pelvic floor problems and resulting in prolapse or incontinence, the risk factors are being overweight, for having repetitive like bronchitis, like repetitive coughing, having multiple births, there's a genetic element, collagen disorders, and normal vaginal delivery. So any vaginal delivery you have is going to have a greater risk of having pelvic organ damage than a C-section, whether you have damage there before or not. What I don't really know the answer to is if you have the prolapse, are you any more likely to have further problems? We don't know. But, you know, the second delivery, you've already widened that canal. I think in this case, it is challenging for you to make that decision, because just carrying the baby increases the risk. So having the section might not be, you might still have problems after. I think you have to really look inside yourself to what you think is the best thing to do, because C-sections carry other risks as well. And trust your body and know your body with it, because you can have problems either way. And what I would encourage you to do is to go back to your consultant and your midwife and talk it through. Ask them very specifically, in your opinion, what are the pros and cons on both sides, and then allow yourself to make an educated decision on what you think is best for you and your baby. Because from a research viewpoint, we're not sure. There's risk both ways, but you know, either way, getting the baby out safely is important, and then whatever happens afterwards, you can manage it either way. All right, so that's a really interesting one, and it is a problem that a lot of women face, because there's pros and cons in each situation. So hopefully that helped. If you want to discuss this with me further, please drop me a message. I'll happily call you, send you the links to these studies, and talk through it a little bit more. Whew, turns out I can easily talk without Ollie. Who knew? All right, thank you everyone that's logged on there to watch that. It was kind of two very different topics. The first one being dealing with a knee meniscal injury, a meniscal tear, and how we manage that. And the second one is, do you or do you not have a vaginal delivery if you're already suffering prolapse? And it is a very difficult decision to make. So hopefully that helped. I am going to go. I am very excited. I'm about to spend a little bit of time with my niece, who you might have heard in the background there, letting out a little yelp. I can't wait to see her. I haven't seen her all week, so we're going to go and have a little bit of fun with them for an hour before she has to go to bed. I hope everyone has a really good Saturday night. Oliver will be back next weekend, so any questions, please do send them in to us, and we will always try our very best to answer. So hopefully that helped. Thanks for watching, guys. Bye.